Hello and good evening to all. Jyoti Patil Shah and I am the Chief Operating Officer at WeCare. We are thankful to all those who have joined in today for an exciting beginning 27 Cancer Survivors Day event. WeCare is a support group for cancer patients and their families for the last 27 years. WeCare had initiated Day in India and now it is celebrated by many of our other patient organizations throughout India. It marks the spirit of grit and determination in conquering cancer. Every year, a series of events are planned physically, both fun as well as informative. The pandemic did not stop us from doing the same this year too. So here we begin with our first event for this week, series of panel discussion. In the year gone by, we came across many challenging situations. Topics of our panel discussions have been derived from our experiences during the pandemic and hence the title Cancer Care and Complexities, COVID and Beyond. Before we begin each of our panel and also after our panel, there will be one poll question which I request all of you to participate. It will enhance the panel discussion and also your insights will add value. Request you all also to post your questions in the question and answer column. It is a great privilege to introduce our moderators and panelists for this evening. So let us set the ball rolling, and here comes our first poll. Can we have the results? Oh, so yes, 77% feel that we do have complex needs. Okay, the first topic, how can care be better coordinated people living with and beyond cancer who have complex needs? We have our very own Mrs. Vandana Gupta, founder and trustee of WeCare and also a cancer survivor who will moderate the panel. And as our panelist, we have Dr. Bhawna Sirohi, consultant medical oncologist, GI and breast cancer, Mr. Rare Cancer Australia, Dr. Kumar Prabhash, Professor of Medical Oncology, Tata Memorial Hospital, and Dr. Sudeep Gupta, Director, ACTREC.
A good day to all of you and welcome, a warm welcome. Extremely grateful on behalf of WeCare and my personal behalf that all of you have agreed to be a part of this panel discussion for our Cancer Survivors Day. As you know, Cancer Survivors Day is a big event for us because we believe that survivorship is an extremely important issue, and that is how we started the Cancer Survivors Day almost 27 years back. So thanks once again, and we'll go straight into the point because we have limited time. So what I want to say is, because of your care, because of the way you handle patients, because of the patient advocates' intervention in some way, and because of the family, we know that there's a growing number of cancer survivors who have come up. And almost 70% of the cancer survivors, 13 million cancer survivors are long-term survivors, which is very, very heartening to know. But as they grow old, there's a lot of, like other diseases or complex diseases or things like, maybe diabetes, hypertension, all that comes in. So what we are talking about is how can care be better coordinated for people living with complex diseases with complex situations. So that is what we are going to be really talking about. The growing number of cancer survivors challenge delivery of high quality survivorship care by healthcare systems, innovative ways to improve care coordination for patients with cancer and multiple chronic conditions are needed to achieve better care outcomes, improve patient experience of care, and also the lower cost. So the first, what I will do is ask a question which can be answered by all of you, which should be answered by all of you, and then we will proceed. So what type of systems and patient factors facilitate or hinder implementation, which results in different experience of care coordination between complex cancer patients with or without cancer? I'm calling them complex not because they are complex otherwise, but because they have multiple diseases like a lot as besides having had cancer. So, Dr. Gupta, maybe you want to start?
Yeah, so thank you very much for inviting me to this excellent panel discussion, Vandana ji, and my warm regards to everyone who's watching this panel discussion. I think you brought up a very important point about how care should be coordinated for individuals who have in the past been diagnosed with cancer. And at the outset, let me say that each human being is both simple and complex. So, you know, there are no complex human beings and simple human beings. Each of us is a complex person. What happens with individuals who have had cancer in the past is that they have some special medical needs, social needs, financial needs, and some other aspects that need to be taken care of. A major focus of the healthcare system is to deal with the actual treatment of the cancer, and justifiably so, because you have to get the cancer under control. But from my own experience in oncology in the past about 20 or 25 years, I have seen that there also needs to be a focus on the continuing needs of these individuals far into the future because of the various medical and non-medical issues that arise. And I specialize in breast cancer, and in gynecological cancers, I have seen that during follow-up, our patients grapple with issues of lymphedema, they grapple with obesity, with hypertension, diabetes, hypothyroidism, and a number of other medical issues that, you know, you can just brush under the carpet. You may not deal with them, but then they need to be dealt with in order to ensure the continuing health of the patient. So we have a survivors clinic in Tata Memorial Center. What we do in our outpatients clinic is to segregate patients who are long-term survivors. We see them, or one of the faculty members sees all those patients in any given clinic, and there is an emphasis on all these medical issues as well as other issues that the patients may grapple with. And here I must say that at least in terms of young women, there are also issues regarding menopause and menopausal symptoms, ovarian function, the loss of ovarian function, and also issues of self-image and sexuality that also need to be dealt with. So all of these things are worth considering when we look at the whole individual and the whole human being during follow-up.
Thank you, Dr. Gupta. Dr. Sirohi, would you like to add on to?
Thank you, Vandana ji. So I completely endorse Dr. Gupta's view. And I feel that new cancer diagnosis also interrupts the existing chronic diseases that the patients may have, you know, hypertension, diabetes, depression. Like I just had a patient today where we fixed a cataract surgery in between chemotherapy cycles, and she could see properly today. So I think this is very important that we don't forget the existing needs as part of the complex care for cancer patients. And also being cancer-free is not the same as being free of cancer. So what Dr. Sudeep said, I also do GI and breast cancers, and we have a survivorship plan built in. Based on my experience in the NHS, I've taken some things which I found were very, very good. Like every patient, when they finish a treatment plan, I would give them a treatment summary, which has things like cumulative dose of, let's say, anthracyclines they've received, and what side effects or what things we need to look out for in the future. So, you know, survivorship is all about prevention of acute or chronic or late effects, is about surveillance for those side effects. We need to look out for those. For that, patient needs to be educated. So if they have something in writing in their own language, whether it's Tamil, Marathi, or Bengali, that's very important. The third thing is coordination between the primary and the secondary care, which I think we seriously lack in India. Most of our patients, they'll be on diabetes medications or hypertension medications, and I ask them, who's supervising the care? They haven't seen a doctor for 3 years or 4 years. So that care is something which we need to coordinate. And the last thing is intervention, when the treatment comes, the treating whatever complications they have. So the treatment summary is important, which includes all of this. The second is, we are trying to set it up here at the Proton Center, the holistic needs assessment for the patient, which will include the physical, spiritual, all the needs that they may have as part of a single questionnaire, which is, not very long, takes about 2-3 minutes, which can be done by a nurse. So we're trying to do it as in a prospective fashion. And the last thing is support group meetings, which I tend to do once a month. We used to do them physically, but now since COVID, we've started doing virtually to look after the, health and well-being of the patients. So these are the things which I feel quite passionate about.
Thank you, Dr. Bhawna. Dr. Kumar, would you like to add on to what Dr. Bhawna and Dr. Sudeep have mentioned?
Thank you, ma'am, for inviting me for this panel. So for me, if we take survivorship, I do divide. There were very valid comments by two of my very senior colleagues. One is that after diagnosis, once we call survivor, that once they have been diagnosed, we call them survivor. What we have understood, at least in our setup, what you put it, there is a complex demands and issues with the patients. And once you get diagnosed, some patients only require some fund, some requires a place to stay, some requires a PIC line. And on these fronts, we have interacted with you a lot. As you are aware of, there's no uniform way of need for them. That is when you do have an active treatment for these patients, and they also are survivors as per WHO definition now. Next group of patients are the disease is well controlled, and many of these patients, they continue on treatment. Like for example, CML, lung cancer, where again, you have been a wonderful partner for patients receiving those tablets, where patients take these treatment for years and years altogether, and it brings out its own issues with the patients. Disease is controlled, but now other issues takes up: how long to come, when to come, how frequently to come, how we can get those drugs to these patients at their home place, the scans. So there brings out a different kind of issue with these patients where disease is controlled, but treatment continues for years altogether. Third group of patients are where you have those treatment completed and we have in follow-up. And then we look for, as a doctor, primarily three things: how is the disease, how we do have a second cancer coming up in case, and all kind of complications because of treatment we give. And this also includes, as Dr. Gupta said it, and if you take, I deal with head and neck cancer, a bit worse one. So you have an issue of facial distortion because of the kind of surgery and radiotherapy patient receive, the swallowing getting affected, the speech getting affected, and it also impacts beyond it, which we do miss it, which maybe we need to work harder on it. What happens to, as far as the lung cancer patients are concerned, for vaccination? What happens to social status? What happens to the job of these patients? Good number of patients, when we talk to, they have been like in sales, and they have lost job because the kind of surgery they have undergone, kind of the facial distortion, other things are there, or because of travel. I had a patient, a teacher from 2,000 kilometers away, who used to come every 3 months for the same tablet, ma'am. And his concern was, my school is not giving a leave. Can I get those tablets there? And if I get those tablets, I can take those tablets and I can continue my job. So yes, we do have complex issues in this situation, but also those individual interventions, complete becomes tough, all of them, but small little, the most important intervention in individual patient bear results. And as again, I repeat, we care helped us for lung cancer patients for crizotinib when they had a huge issue. And once the crizotinib issue started reaching their home, they were okay. They were so much of anxiety initially, but once we care put things in place and the tablets started reaching their home, they wanted to talk to us on Zoom, but they were happy with those tablets. Then their anxiety of coming every few months to TMH had waned off, suggesting that you do have many complex problems, and we will learn as we keep discussing in the panel.
Thank you, Dr. Prabhash. Richard, you and I belong to the same category of patient advocates, and we always have something different to say to what the doctors will say. Of course, doctors treat and they do the best that they can do, but we know that we, the patients, face a lot of problems. So, would you like to talk about something?
Yeah, look, thank you, Vandana, and hello, everybody. I'm coming to you from Australia, where I run an organisation called Rare Cancers Australia, and I was pleased to hear one of the previous speaker talk about the complexities of the individual and how that impacts survivorship, because essentially, when I'm at my most enthusiastic, I describe every cancer as being unique, and therefore it's rare, and therefore we control the world. But it is an important point that anyone who survives cancer, and the good news is that more and more people are surviving cancer, will come out with a unique set of challenges and a unique set of problems. And they won't just be health. Health will be there. It will be important. Right now, we're seeing with lung cancer patients that in particular, but anyone who's been through chemotherapy will be susceptible to COVID, and therefore needs to be prioritized for vaccines and needs to be extremely careful. And it's wonderful to hear that you've got vaccines in India, because we haven't got them here yet. But the other sorts of problems that people will have to deal with, just the fact that you've been diagnosed with cancer and you've survived will probably leave you with some financial challenges. You may not have been able to work. You'll certainly have emotional challenges because you've been confronted with a life-threatening disease, given that you have overcome it. And as I said, it's great that increasingly cancer is not a death sentence. It's a treatable condition. Is wonderful. And all of those are important, and they need to be monitored. And one of the things that we do, and I think one of the things that VCare does, is try to build a platform of care that goes beyond the actual treatment cycle into the well-being or the holistic approach, as we said before, after that, because you can't go through months of chemotherapy or being relocated. We both Australia and India are vast countries. Just we have a lot smaller population, but people are still traveling long distances. They have to get back to their homes, and all of these things are consistently building in their minds as they come out of cancer treatment. So I think that this approach of actually understanding that when someone has beaten cancer, there's still a lot of work to do is really fundamental to what we do. And it's very much for me, Vandana, sits in our world. That's our job in the patient care world, to be supportive of these people as they come out of the tunnel of treatment.
So we all agree that there are poor and there are under and uninsured individuals, and that also reflects on the complexity of their life further on, because they might have spent a lot of money during the treatment, and then how do you carry on with life? That is a big issue. I think that has to be really understood by the healthcare professionals and also the advocates who are dealing with the patients, because we can't just say that now that you are treated, go back to normalcy. It doesn't happen, because they might have taken loans for their treatment. Something might have happened for them to lose their, so many people in India, we know, sell off their lands, sell off their houses to be able to complete the treatment. And then what? That is a big question. So we need to move on to the next question. What type of care is required to ensure optimal outcomes for their cancers, coexisting chronic condition, and overall quality of life? May I ask Dr. Prabhash to please start on this?
From it.
Sorry. So chronic condition and what interventions we can do to have an optimal outcome. It is important, especially because what we have seen in most of the adult cancer, that almost one-fourth of the patients, they do have some or other chronic condition, suggesting that they require interventions. And I'll give some example to illustrate. For example, geriatric patient, it is good to get it evaluated in geriatric clinic, and which we have started at TMH, so that all geriatric patients, whenever we want, we send to the geriatric clinic. We get an evaluation to know what is the best way to. It helps you. The information helps you in defining what way you want to intervene in, in these patients as far as the active treatment is concerned. Next is, if you have those patients who are not geriatric and you have those multiple comorbidities, then you do have patients on many treatments, many drugs. And because of these drugs, you do have again many interventions, either radiotherapy or surgery or chemotherapy, which may interact with these drugs, and that becomes a challenge to administer these drugs. And that awareness again becomes important when we decide active treatment for these patients. The also challenge comes in how to monitor those comorbidities. So if you have a blood sugar, you have given treatment, you give some steroid for vomiting, the blood sugar shots up. How long we give, how the infection will come up, and those becomes a challenge, which awareness is useful when we are dealing with patients with multiple comorbidities. Another example for us has been the like arthritis. Patient is on immunosuppressive drug, and then we are giving some more immunosuppressive drug or myelosuppressive drug. How that will interact and what kind of infection will have, again becomes a challenge in this setting. Apart from this, the drugs and the treatment or itself leads to chronic problems. I give cisplatin, a lot of them. Good number of patients develops a neuropathy and what we call loss of sensation in the hand. So disease is good, they are without disease, but on follow-up this becomes a challenge, how they are going to live their social and their life of where they work and take due precaution, so they are able to have the active and optimal life. And those interventions sometimes are very small. Maybe we can't treat neuropathy, but those interventions, what kind of shoes you're going to wear, what kind of needles you're going to avoid, when you're cooking, what kind of precaution you take, these are the things which many times avoid those disasters which can happen if we don't tell our patients.
Thank you, Dr. Prabhash. Richard, would you like to add on something?
Yeah. Look, I think going back to, I'll be brief, but I think this concept of ongoing supervision and the way the health system works, and I think both Australia and India systems work a little bit the same, which is that you go through a treatment regime, you reach the end of it, it's successful, and there's and then you stop being supervised. And for example, my wife, who is a long-term cancer survivor, was on a clinical trial last year, and went through the clinical trial, and for reasons of comorbidities, for want of a better word, had to withdraw from the trial. But she'd been kind of referred by the oncologist onto the trial, and the treating oncologist on the trial was running the trial. And when she came off that, it's kind of, where do I go now? And I think that's a little bit of what happens in survivorship. If you go through surgery, you have follow-up chemotherapy, and then you're finished, and then who's monitoring you and who's making sure? And I think that's a really, not just, it is part of medical follow-up and medical treatment, but you almost need a case manager that goes with you, where you've got a point of reference to sort of start the process again, because otherwise you start to, we see patients missing scans and not doing appropriate follow-up and kind of pretending that it's all right and that they're actually cured, whereas they're in fact surviving, which is a different thing, and they're living with the disease. So I really support that. I think that's something that making sure a patient that's completed a course of treatment doesn't fall out of the system it's complex, but I think it's terribly important that we do that.
Yeah, I agree with you. So, Dr. Gupta, would you like to say something on it? Your comments?
So I believe the point of discussion was to ensure optimal care during follow-up and how to improve the quality of life. Was that the point of discussion?
Chronic conditions and improve the quality of life. So we have to take care of the after cancer, the morbidities which are there, and also improve the quality of life. All the three things.
So, I agree with the comments made by the previous two panelists on this point. I completely agree with them. Um, my only additional points are two. The first is that, as I think Dr. Sirohi had also mentioned earlier, these days at every stage of care, uh, the evaluation as well as management is getting standardized and to some extent algorithmized, if I may use that word. So, one does need to have a standardized way of following up patients so that we don't miss out on anything. So, for example, again, taking the example of breast or ovarian cancer patients, when they follow up with me, I can, do a physical examination to check whether the breast cancer is all right and it is under control. I can look at the mammogram, I can look at the ultrasound and CA125. But, I will not be able to evaluate whether they are having hypothyroidism or they are having premature menopause or they are having problems with with sexual issues unless I do it in a standardized manner in all patients. So one particular aspect of improving the medical aspect of continuing care is to standardize the follow-up. But the only other point, and I think the most important point that I want to make is that these days, everything is reduced to a form or a chart that one has to fill out sometimes on the iPad or on the phone, but that is not equivalent to care. And one thing that I find very deficient, increasingly deficient, including in myself, is the quality of the physician and patient interaction or the survivor interaction. And I think nothing replaces a good, person to person chat, even if it is only for 5 or 7 minutes between two individual human beings. And I think what is getting lost in all of this modern way of thinking is that you have to fill out forms, you have to enter things on the computer, you have to do this, you have to do that, you have to do a number of tests. But many things actually come out when two human beings have a nice good chat with each other, even if it is only short lasting. So I think I do want to emphasize that point. And the only other last point that I want to make is that, you see, when we have patients with diabetes or with hypertension or even with many other, let's say some cardiac issue, we don't call them, we don't put labels on them. And to some extent, I think we should not make cancer patients who become well and whose disease then becomes controlled to other them. So I think, in some ways it is good to have a term like survivor, but I sometimes wonder whether it is a good idea to have such terms or not. I mean, you don't call a patient with diabetes as a survivor, you don't call a person with hypertension as a survivor. And you see, the more I mean, the whole idea is to integrate these individuals back into the normal way of life. And I think that cause is not helped if we continue to emphasize the fact that you once had a cancer, and now you're surviving it. I mean, there are patients who are 10 years out, who are 7 years out, who are 14 years out, and you still look at them as a so-called, a patient with cancer. So I think, to some extent, I don't know whether all these labels of survivors and others are actually, they 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 put a kind of a mental block both within the healthcare community and the patients and hamper their integration back into the normal way of life. But I'm
So,
sure that there are many opinions on this.
yeah, Dr. Gupta, one thing is that, we like to believe that if you have diabetes or if you have hypertension, you are never a survivor because it's going to be on for the rest of your life because you never get out of it. But as a cancer patient, especially me as a 27-year-old cancer patient, would like to believe that I'm a survivor because I've finished with my journey of cancer. So I don't know, there can be two views. Dr. Bhawna, would you like to comment on this issue which Dr. Gupta has brought out?
So I think we've had a lot of discussions with Sudeep and one of our dear friends, Shona, as well, at various support group meetings. We've done the national survivorship meetings. And patients are very passionate about what they feel. Either some would prefer the term, some would not prefer the term. So I think I am absolutely fine with it because I feel the key thing is in survivorship, whether it could be diabetes and hypertension survivorship as well. It has to be about adapting care to the needs of that particular patient. Because even in diabetes, you need to have a plan for kidney, neuropathy, and so many other things. And similarly, I think for cancer, we have to do lots more, not just in India, but in high income countries as well, to destigmatize the word and, to think of it as something which, is there. Like in any film, whether it's a Hollywood or Bollywood, if the protagonist has to die, they end up having cancer, which is so sad. It could be anything, but, that's very sad. So we need to change the narrative. That is the key thing here. And for me, I think for survivorship, there are so many things we can do, both in high and low and middle income group countries. For me, young women with breast cancer is the most complex. Of course, every cancer patient needs an individualized plan. But for young women with breast cancer, they're at a time of their life and they're either starting their career or their family or they're planning a family. So a genetics consult. When we did the support group meeting, I think genetics and the vaginal dryness had the maximum breast cancer patients who attended those meetings. Because I think we need to address this genetics, which is a huge thing for them, especially if they've not completed their family, not got married, they're starting work. Sexual health, body image, fertility, planning for the future, cognitive effects of the treatment, which we don't talk about, especially with chemo brain and side effects relating to hormone therapy. But they're quite significant when we see patients in the clinic 3 years out, 4 years out, the beauty concerns, emotional health. So I think we need to address these. And I agree with Sudeep that, we're creating these forms. But it does help us to tick all those boxes. It's like a checklist that sometimes patients may not voice those concerns, but I think if you have a checklist in front, it's important to do that. If I ask a patient, do you have hot flushes? They will say yes. And then you ask whether you wake up in the night with those hot flushes and they say yes. They sometimes have to change the bed sheet as well because of night sweats. But because I didn't ask, they never told me. And so I find this out in a support group meeting. So I think this is very important that, we address all of these. So for that, one can have hot flushes clinic, lymphedema clinic, psychological support. So there is lots more we can do. Cardio-oncology is coming up as a branch for survivorship as well.
So like you and Dr. Gupta both mentioned that you need more time with the patients, which means it can't be a 2-minute Maggi noodle. It has to be like a well-cooked dish which is being produced. So you already mentioned about, that doctors are only looking after the oncology bit of it and the other aspects are left out. So Richard, Dr. Kumar and Dr. Gupta, would you like to add on to this to say that do you also believe what Dr. Bhawna said that, you all are concentrating only on the cancer aspect but are missing out on the other aspects and not really interacting with the primary doctors, the person who might be treating the patient earlier?
If I could, I'd like to make a point slightly off that topic, but back to this idea about that Dr. Gupta raised about whether survivorship's the right word or whether it's the right label. I think it's a good question, but I think one of the things that holds back a lot of cancer care is this the stigma that comes with it, and I think celebrating survivorship actually helps to alleviate that stigma. And I think we should all be really conscious of that, because if, at the end of the day, we want in any country, we want better funding. We want more engagement from governments in how we treat cancer patients. And one of the things that we need to portray is a sense of increasing optimism about what it means to have cancer and how you can survive it, and how all of the investment that we might make in the education and growth of an individual and what they contribute back to society through their parenting and their work is not wasted, because we can beat cancer, we can survive cancer. And I think if we want governments and society generally to be supportive of improved cancer care, that we have to find a way, and survivorship is one, to present it as an optimistic, that we can be optimistic about cancer now. It's not what it was 20 years ago. It's not what it was 40 years ago. And 10 years from now, it's going to be even better if we get it right. And things like CAR-T and better surgical techniques, better radio oncology, all of these things are hugely positive that we need to portray. And one of the best ways to portray that is talking to people who've been there, and people like Vandana who've survived it and lived incredibly productive lives. The contribution, if I can say so, Vandana, that you have made to society in the 27 years since you overcame your cancer is priceless. And no government could ever underestimate that contribution, and whatever it took to get you through it was a bargain. So I think we just need to have that perspective when we think about how we talk about survivors. It's very important.
So, Dr. Prabhash, do you think the need for a continuous journey of the patient, like from maybe whatever the primary doctors may have been, not cancer doctors necessarily, or the other doctors who will join in after the cancer treatment, do you think a balance can be done, whether you can interact with them or collaborate with them to give better care to the patients?
Yes, no doubt about that. The moment you start interacting with your colleagues, and we can call with whatever name, and I agree with Dr. Gupta. Sometimes labeling has its negative impact, but we also know many times labeling an issue has had a positive impact in the history. And as our ex-RBI governor, Mr. Raghuram Rajan said, for everything, try a bit. Let's see what happens. If results are positive, continue doing it. If but we do know that subsequent care is required, in these patients, and the treating people. We do a bit in the TMH, which is internally, but as Dr. Gupta said, our interaction with other clinicians, the primary physician who handles them at local place, that has been very improve upon. Somehow it has been not so great, but with your colleague, with the other department, with other specialty, it does improve the patient outcome. Sure, this should have a similar impact in this situation also. Yes, it is a different issue that at this moment, in this situation, we are interacting very less with our colleagues.
So, Dr. Gupta, can I pin you down and say that, now I can ask all the patients who have some other issues to ask you to give a referral for the doctor who's treating them, or would you be able to suggest another doctor for them?
So, Vandanaji, what happens is that most of the panel discussions tend to, become politically correct. But, there also needs to be a little bit of a dose of realism that needs to be injected into such panels. Otherwise, they become utopian ideals, which, are good for that half an hour of panel, but, which is actually not followed in the real world. So, I have worked in the US for some time, and I've never worked in UK, but at least in India, there is no hierarchical system of collaboration between primary, secondary, and tertiary levels of care. And whatever I may say in this panel here, the fact of the matter is that at least in the Indian setting, there is hardly any collaboration between tertiary care doctors and the neighborhood clinic or the usual doctor that the patient goes to. And this is not just true of oncology; it is for everything: cardiology, gastroenterology, everything. It would be, of course, be ideal to do that for continuing care. But the large majority of patients in India don't even have a family doctor. And the other thing that has become a casualty in the modern world is actually the primary care physician or the so-called family doctor who used to be a confidant of the patient, and in whom the patient used to whom the patient used to go not only for medical care but also to confide a variety of things. So now, my own suggestion is that, it would be ideal to do that, but I don't know how to bring this about in a situation like India where care is so fragmented. Patients go to a tertiary care hospital, they come to me for, every 6 months for follow-up for their breast or ovarian cancer or cervix cancer. But in between those 6 months, they go back to Raipur. And, I don't know the person in Raipur who cares for them for their hypertension, diabetes, or whatever else. So it would be ideal to do that, but that system doesn't exist here. So maybe, you can suggest, because you are a patient advocate, let me put you in the hot seat. Please suggest a system how to coordinate this care.
Okay, thank you for putting me in that seat. And I'm going to ask Richard in the last few minutes to talk about it. But we know that we need to look after patients, also empower the caregivers, because as the statistics are, that by 2022 we will have more than 18 million cancer survivors. So if we are going to have such a large number of people living with cancer, we have to have better care for them. I know everything will not work out as we want it to be. As you said that, it may, what we may talk here may be something which is very utopian. But at the same time, I would like to have one thought from each of you now about, your future blueprint. Suppose you were the health minister, or suppose you were the person in charge, or suppose you had all power to change things. What would be that one thing that you would do to improve patient outcome, caregiver responsibility, and better healthcare? Dr. Bhawna, let's start with you.
Okay, so I think, Vannaji, we need your clones in every cancer institute. So we need champions in every cancer center who actually drive patient information, because I feel an informed patient is an empowered patient and can bring the change as well. I think that is very important for shared decision making. We call this shared decision making between the clinician and the oncologist. So I think if one thing I could do in India would be to have champions within every cancer center for survivorship, and also peer review treatment guidelines and protocols, especially in the private sector. I would really want that in India.
Okay, Dr. Gupta.
So, if I had the power to do just one thing in terms of cancer care, then I would have more surgical oncologists, radiation oncologists, and medical oncologists in many more parts of India, with adequate infrastructure in terms of, operation theaters, training, radiotherapy machines, and chemotherapy drugs to treat patients. That is what I would do.
Okay, Dr. Prabhash.
I agree with the previous comments. Just adding one more, we know some numbers of our cancer patients. If somehow we can track them, they were able to get minimal care. We do have those hundreds of medical colleges with hundreds of radiotherapy machines. We do have a shortage of manpower, but then also we do have many services available which can be optimally utilized. So if you can track them, how many of these cancer patients were there and were they able to get minimal care? If you can track, I think so that can have a big impetus in improving the outcome.
Thank you. And Richard, as a patient advocate, Do you think that the principle of process improvement, appreciative inquiry is what is required? It's the process of the plan is do, study, and act. Should that be the plan? Would you like to comment on that?
Yeah, I was going to say, you asked me if I could change anything, and I think the first thing I would change would be the result of the last cricket test. But notwithstanding that I can't do that, I think, yeah, I think we're talking about the same thing, which is that this problem exists in Australia equally as it does in India, except the scale of the challenge is much larger in India. But I think that we're exploring ways of having not clinical people, but non-clinical people acting as sort of navigators for patients and navigating them in a psychosocial way with financial help or advice, with someone to be there to talk through the emotional things. That it's just, you know, the medical profession does amazing work, but it can't do everything, and there are people that we can build almost a kind of allied health profession. That's what we're trying to do here, to train people so that patients always have someone to talk to. They're not trying to in any way offer any clinical advice, but just to be there and to say, well, you know, have you been for your checkup? Have you done this? Have you done this? You know, have you spoken to these people about financial support or emotional support? And I think inevitably, and it's something that's increasingly in my mind as we work in multiple countries, is that the patient care organizations can do so much to help, just with all of the more, to go back to Dr. Bhawna's comment before, the holistic treating all of the patients, all of them. We have a phrase here: we treat the person and let the clinicians look after the patient. You know, and that's I think something that would help enormously as they come out of treatment into survivorship, or a more appropriate word. And I do want to say that I completely understand Dr. Gupta's concerns about it, because it's also the concern around, is cancer a battle or a war? You know, we talk about living with cancer, or experiencing it, but not that it's a fight. And I think the terminologies are important, but and how we get that right. But underpinning it all, there has to be an optimism that is not always been there. So that's me.
Thanks a lot to each one of you. And so I think the 4 key elements that have come out in this whole discussion is that we need to have an internal motivator. We need to have an external motivator. We need to have resources and opportunities, and then we can bring about the change. It may be small opportunities, it may be small resources, but once we are on the step of doing those things, you know, if we can start working on that, today it may be a small step, tomorrow it might be a bigger step, and then as a collective agency, we can all take bigger steps. As Richard mentioned that, you know, 20 years back, cancer treatment was different from what it is now. In the same way, things can be different from what they are now if we all consciously and collectively work together to move ahead. So do you all agree? Yes or no? And then we can wind up.
Completely agree, Vandana ji.
Thank you, Dr. Bhawna. And Dr. Gupta, anything to add?
No, I have nothing to add. Thank you very much. I thoroughly enjoyed listening to everybody's perspectives.
Dr. Prabhash? Richard? I think Dr. Prabhash is on mute.
Yep. No, nothing at all. You've done thank you. It's been wonderful, and I'm very grateful to have been invited. It's been wonderful. Thank you.
Thank you once again for being here, for supporting us, and for encouraging us, because VCare can function only with the support of our medical doctors and our advocacy people who can help us in learning more and moving ahead. Thanks a lot. Thank you very much.
Thank you so much. Thank you.
Bye.
Thank you, Vandana ji, for this wonderful discussion. We have a few questions, if you can just take in for our panelists.
Thank you, Jyoti. Dr. Sudeep Gupta, there's one question that has come from somebody who says that she's very young and she's got breast cancer. So, should she go in for ovum preservation? Is that a good thing? Because in the long run, it might be a complex need that has to be fulfilled. So, what do you want to say about it?
Hello, good evening, Vannaji. Can you hear me?
Yes, I can.
Right. So this is a very good question. Fertility preservation is a very important aspect of survivorship. Ovum preservation or embryo preservation are some techniques to preserve fertility, and they are options, but they have to be discussed by the patient with the treating oncologist as well as a fertility specialist. And there are several nuances and several other considerations that are involved. And I think this needs a detailed discussion between the patient and her fertility doctor as well as the oncologist. I cannot give a yes or no answer here.
Okay, thank you. So to take it further, Dr. Bhawna, since you are also dealing with both women's cancers, that, have you seen how many people really get married after having breast cancer? And so what would you advise them about preserving their ovum if they are not married?
So I think I wouldn't let breast cancer stop anything normal that you would do. That is what I sincerely advise patients. I've had so many patients, not one, but so many, who have actually, especially if they've been diagnosed at a very young age, who've become pregnant naturally after, at least 2 years of treatment. Some of them are on hormone therapy. We suggest, you continue 2 years and then try to get pregnant. Some of them have not been able to, but then they have used either the embryo that has been cryopreserved if they are married, and or if they have a partner and they've had their embryo cryopreserved, or have had their eggs harvested, which have been cryopreserved, and they've used those eggs to become pregnant. There is also something else that I suggest for all women who are going to undergo chemotherapy. We give them an injection to suppress the ovaries called, it's an LHRH agonist. Basically, it suppresses the ovaries, and the thinking behind it is, chemotherapy acts on cancer cells that are dividing, and if the cells are not dividing, then maybe this would not act, and it's part of the guidelines as well now. So all premenopausal women get this injection for fertility preservation and also to prevent premature menopause. So I would actually, sincerely advise, don't let the diagnosis of breast cancer, especially with young women with early breast cancer, stop you from leading a completely normal life.
Thank you, Dr. Bhawna. Dr. Prabhash, there's a lot of talk going on about the farmer protection, farmer laws, all those things. So one thing that has come up is, that farmer protection for cancer, as they are using pesticide in farming. So what would your take be on it? Would you advise to have pesticides in farming, or do you think organic is the best to do? And how can they make their money on it? So Dr. Prabhash, can you please answer this question?
Madam, I heard your question. As on date, there is no definitive evidence regarding the pesticides and the cancer. So to say one way or other will be not the best statement from our side. So right now we leave it to have some more evidence to suggest does it really lead to cancer or not. Till we have that evidence, we should wait for it.
Okay. Richard, there's one question which I would like to ask you is that, we hear a lot about this 5G, mobile phones, all these controversial things, and they are going to be there now, it seems, even more than what they were earlier. So what is it like, does it cause a lot of cancer? What is that you have heard as a patient advocate, are you talking about?
Again, this is another situation where there's a lot of hearsay. Evidence has been pretty iffy regarding this, that mobile phone leads to predilection for cancer. So I'll say maybe again here we should not derive the conclusion that mobile phone leads to cancer at this moment.
Okay. Thank
We
you.
had
Richard,
no
would you like
evidence.
to add what is it in your
Yeah,
country?
there's just simply no evidence that it's a problem. It's been 5G is being implemented across Australia with no evidence of any disease or anything associated with it. There's a lot of what I would call sort of bad information, superstition around it, but there's nothing as yet that anyone has seen that other than that it's just no different to 4G, it's no different to 3G. If they're all the same basic technologies, just a slightly different intensity, and I think there's no evidence to suggest there's anything to worry about at all.
Okay. So, Dr. Gupta, one last question maybe, which I think all of you can answer, is like, there are so many concerns that patients have that you as a doctor have for the patients. Just one thought, like a motivational quote that you would like to give to the patients. Dr. Gupta, you can start, and Dr. Bhawna next, and so on.
So my message both to doctors and to patients would be to keep our morale and optimism high. There are a lot of advancements in the treatment of almost all cancers, and especially some cancers, and the outlook for getting cured as well as for living a healthy life are far better than they used to be earlier. And I think the whole community, including advocates, patients, doctors, other healthcare personnel, should collaborate and see to it that we achieve ever better outcomes in our patients. That would
Thank
be
you.
my message.
Thank you. Dr. Bhavna?
So my only advice, Vannaji, would be that 50 to 60% of cancers are preventable. Yes, you have developed cancer, but I would suggest that, for your loved ones and for your friends and family around you, there are enough screening tests which are recommended by various national and international societies, which you should discuss with your physician, or when you go and see your oncologist anywhere, wherever you are. So like for colon cancer, breast cancer, cervical cancer, there are certain tests that you can do to diagnose cancer early. So I would suggest, take charge of your health.
Thank you. Dr. Prabhash?
The similar opinion as expressed by Dr. Sudeep, that don't lose hope. There are many development in recent past. So there is hope there in cancer today.
Okay. Thank you. Richard?
Yeah, Vandana, I would just say there is no shame in being diagnosed with cancer. There is no reason not to have hope. There's no reason to see it as a stigma. And there is no reason not to ask for help, be it with an organization like VCare, be it with these esteemed doctors that we've had on the call today. There are lots of people out there, lots of people that will help, and you will need help, because it's living with cancer takes a lot of effort and a lot of time, but there's nothing that you've done wrong to get it. And you should be aggressive about getting out there and letting these wonderful doctors treat you and ensure that you live a very long life. Be optimistic, but be quick to act. And we're running a campaign in Australia at the moment with a number of people, which is a number of other organizations, which is called New Normal, Same Cancer. And it's all about saying, we know that COVID's here, but don't let that stop you going to talk to your doctor. That's really important. And get on top of it. The faster you get there, the better you'll do.
Thank you very much. Thank you, Dr. Bhavna, Dr. Gupta, Dr. Prabhash, and Richard. Like they said, the head controls the body. So let your head be positive, let your head be clear, and let your head have all the information to be able to do better. Thank you very much.
Thank you. Thank you.
So here goes our second poll question. Can we have the results, please? Okay. So 75% feel that we are, we do have complex needs which can be taken care of.